This is the overview of the talk, and I'll let you read this, or I'll read it out to you. Mr. Evans is a 72-year-old with coronary artery disease and congestive heart failure. He arrives for an office visit after fainting yesterday and reports lightheadedness for the past 2 weeks. When you feel his pulse, you notice that it is irregular. You perform a history and physical and get some lab tests to determine his cause of atrial fibrillation. When you ask Mr. Evans to schedule a follow-up appointment for the next week, he says he can't come because he's about to see his new grandbaby and has to drive there for a 2-day trip. Would you address that driving issue, and if so, how would you address it? What would you communicate to the patient?
I have to say that whenever I've in a situation like this, I don't think I would have addressed the driving.
Okay.
He actually had a syncope episode then? He had a syncope?
Yeah. Mm-hmm.
He actually did pass out.
So you shouldn't drive for 3 months, right? Isn't that
Oh, he
the-
fainted.
We'll talk
Right,
about
is
that.
the law?
I'm sorry, I was focused on the lightheadedness. Yeah.
No?
If he truly fainted, yeah.
He did faint, yeah, and he's had some lightheadedness.
He has a new condition that you're just starting to work out. You don't fully know what the outcome is going to be. You're just starting treatment, perhaps, and he's susceptible to having it happen again, and you would be in danger to himself and others on the road if you were to have it happen while you're driving.
True, exactly. So the comment was, since he did faint, if he had another episode, he would put himself and others at risk of major injury or death even. So consensus here sounds like we would hold off on letting him drive until we've got some answers what's causing this. Absolutely. So our population is aging. The 85 and older group is growing the fastest, and those are the patients at highest risk of driving impairment. By 2030, 70 million, up to 20% of the U.S. population will be over 65, and a large number is not going to be able to drive anymore. But our society is highly mobile, so it's really critical that we continue to drive. Oftentimes there is no public transportation available. About 85% of the population have driving as their only mode of transportation because there is nothing else available in their area. And men, after they're not able to drive anymore, live on an average another 6 years, women another 10 years. So we really need to find some solutions to this problem. And it can lead to depression and a number of other problems. So a lot of patients already self-restrict their driving. They oftentimes don't drive after dark, and we'll talk more about vision changes. And a lot of people make only right turns to make it easier. Others don't go out of town. They only go to familiar places. And those are helpful self-restrictions. So our traffic accidents are very high in the teenage population, but then also increase exponentially after age 70. Between 60 and 70, the number is still very small and lower than average, but then it increases exponentially after age 70. And a 4-fold increased risk above average over age 80. So roundabouts seem to be the safest solution. And when I say that to an American audience, they'll all go like, no. And that's because the U.S. did not have roundabouts for a long time. They've only lately come into being. Europe and the rest of the world has had roundabouts all along, and I grew up with it in Germany, so it's not an issue. The reason they cause less accidents and many, many less fatalities and injuries is because when there is an accident, it tends to be a rear-end collision rather than a T-bone as in normal intersections. Also, traffic slows down around a roundabout, so it is oftentimes just a fender bender if there is an accident. But once people get used to them, they really like them because you don't have to come to a full stop. So it is actually also more environmentally friendly because you don't have to do the stop and start, but it's also less noise polluting because you don't have to do the stopping and starting.
They haven't learned that in Baraboo yet with their new
Oh,
roundabout.
my God.
So how many roundabouts do you think you have here in Baraboo?
4 or 5.
Okay, so 4 or 5. All right.
Because people do not know how to use them.
No, it,
Complete stop.
yeah, exactly. So that's my big pet peeve too, that people come to a complete stop at a roundabout before they enter it, and they just don't flow, go with the flow. Yeah. For older drivers, compared to younger drivers who have just not the experience, older drivers oftentimes lack attention or have poor vision. So some of the aging changes that occur, one of them is more sway. So pretend like I have a pen on the top of my head and a piece of paper on top of that, and I'm told to stand real still. Well, a 6-year-old is kind of all over the place. Why do you think that is?
Attention?
Hyperactive? No. Their nervous system is not quite mature, so they are not as balanced. Then it's about, our reaction speed is about as fast as it's going to get when our teenagers start driving, and that's why they don't kill us all, because their reaction speed makes up for their poor judgment. But after age 30, then it's downhill from there, and that's why we're at higher risk of falls. But it also takes longer for the signal from our foot to our brain and back to our foot to change the foot from the gas to the brake pedal. That is one reason why we're at increased risk of falls. So, big risk factor is having had an accident or a traffic ticket in the last year. So ask our patients about those things. And then depression, falls in the previous year, sleep apnea, all can contribute to it. Older driver crashes oftentimes involve multiple vehicles and left-hand turns, and also oftentimes yield signs. That is the biggest one here. So this line here, anyway, you see the biggest line is yield signs. Where do we encounter yield signs?
Country?
You have to make a quick decision about whether you need to yield or not, or whether you want.
Yeah. So yield signs occur most commonly on on-ramps to the interstate. And oftentimes older adults don't accelerate fast enough, and that then leads traffic to back up, and most cars can slow down enough, but if there's a big truck that's loaded, they oftentimes then crash into that whole row of cars because they cannot slow down fast enough. And that has to do with reaction speed and the judgment. Most patients want physicians to tell them not to drive rather than family members, and I fully agree with that. I'd rather be the bad guy than to have the only daughter that takes care of them tell the patient not to drive. And we as physicians can do a lot of things to keep our patients safe on the road longer. We can make sure that their vision is intact, or if they have cataracts, send them for cataract surgery. See if they have arthritis that could impair them, then do something, give them some assistive devices in the car to make them safer, and so on. So we have a lot of tools. These are some studies looking at when physicians told patients not to drive anymore, and only about 10% of patients then did not come back for their visit in this study. I have never lost a patient when I told them not to drive anymore. Most patients have dementia, and I tell them not to drive because of dementia, and most of them don't remember the next time I see them that I told them not to drive. One patient was an exception. He came into the office, and we had a very small office in North Carolina, only 4 exam rooms, so I could see all my patients coming in and going out. So this guy was walking in, and he had a cane, but he wasn't using it to walk. He was teeter-tottering from one side to the other, twirling the cane, and poking it at people. And I'm like, oh my God, this is totally inappropriate. His wife slipped my secretary a note, who gave it to me, that said, please take his driving away from him. And I'm like, oh yeah, I got you pinned. Absolutely, you're totally inappropriate. So this was early in my shortly after my training, and I had just read about the trail making test B, so I thought, well, I'll do this trail making test B with him. I gave it, and I'll show it to you in a few minutes. Well, he was a retired president of a community college, a PhD educated person, and he finished it before I did. He had a 30 out of 30 on the mini mental status exam, and I'm like, how am I going to tell this guy not to drive anymore? I had no objective findings, which oftentimes happens. But he clearly had frontotemporal dementia. It was totally inappropriate. So I just wrote the prescription, and I said, do not drive anymore. Executive decision. And I'm the doctor, and I'm telling you that. So he came back, and for 3 visits afterwards, he would always remind me, I still don't like you taking my driving away from me. And that's because patients with frontotemporal dementia still have intact memory. It's just the executive function is impaired. So he clearly could not drive anymore. However, he still remembered it. But it did not fracture our relationship. Male physicians are more likely to step out and tell patients not to drive than females, so we really need to step up to the plate as women providers. So is our patient at increased risk of driving? You all already said yes, he is. So I agree with that. We need to do some more workup. So signs of impairment when you look at the patient, when you walk into the room, can be impaired personal care, poor hygiene, being unkempt, wearing clothes that are not matching or soiled, and so on. Impaired ambulation, like my patient who was teeter-tottering, difficulty with visual tasks, and then language and memory impairment, and small amount of movement. So look for visual and hearing impairment, cardiovascular disease, as it was in our patient in the case, neurologic, psychiatric diseases, diabetes, particularly if they're on medications that cause hypoglycemia. And with the newer medications that are out now, the DPP-4s and the GLP-1s, we have much less hypoglycemia. So I have switched most of my patients over from insulin to these newer drugs. And then look for arthritis and foot abnormalities and respiratory diseases. Looking at the medication list, anticholinergics are the biggest offenders. Just think, if you don't have a lot of acetylcholine floating around in the brain and then you use an anticholinergic drug to knock out what little acetylcholine there is, you could worsen their dementia, cause confusion or delirium in our patients. And most of the psych drugs can impair driving. Then on the review of system, ask about fatigue, about sleepiness, again, vision and hearing, vertigo, dizziness, and memory loss, and a slow response. So ask specifically, was there a recent crash, a recent ticket, any near misses, getting lost, any poor vision, and cognitive changes. Let's talk about vision. As you've probably noticed, in our older adults, the pupils get much, much smaller. And a most dilated, dark adapted pupil in an 80-year-old is about the same size as the most constricted pupil in a 10-year-old. Huge difference. Part of it is because the ciliary muscle is not as strong to dilate the iris, but also the lens does not flatten out as much. That's why I went to bifocals a few years ago. But lots of reasons. Then apoptosis of the rods and cones in the back of the eye, more clouding of the lens in the vitreous, leads to only a third of the light getting to the back of the eye at age 80 than at age 20. So huge decreases in vision. So in terms of assessment, ask, how did you get here today? Did you drive? Are you having problems? Has anybody voiced any concerns about your driving? And what would you do if you had to stop driving? If they say, I don't know, you can ask, well, what did you do when you had to get your car in the shop for repairs? And that might help you out. And then ask about resources. Do you think you're a safe driver is a loaded question, because patients with poor insight are not going to be able to do that, to say that. But some patients who are still cognitively intact might have some other difficulties such as arthritis, and you might still get some good answers out of that. Have you ever gotten lost? Any violations or near crashes? It's a good idea to just address driving on a regular basis before it becomes an issue. Just say, let's say at age 65, let's talk about driving, and then we'll address it again at age 70, at 75, and at 80. This way it becomes a normal part of conversation. Same thing should happen with advanced directives and so on. Is there anyone who can give you a ride? Can you use public transportation? If people live in an assisted living, they usually provide transportation of some form or another. This is a driving contract that I recommend to all of my patients early in the disease process. If the disease has progressed too far, it's not helpful anymore because the patients don't have the insight. But this is a letter that patients can sign, and it says, if my daughter or my son, healthcare power of attorney, whoever it is, gives me this letter, it's time to turn driving over and not drive anymore. But I also encourage my families to adapt it to whatever they need. And I did that with my parents a few years ago, and I made it very general. I just said, whenever my daughter, Gabriele, who lives in the same town as my parents in Germany, gives me this letter, it is time to turn decision-making capacity over to her. And that then includes placement in a facility, decision-making, but also driving. It's just more global. And this is just an example, and the link on the website is on there. It has the new letter. It looks a little bit different on the website, but the website also has some really helpful videos. But I encourage my families to just compose their own letter. So this is the website, and these are some really good vignettes and scenarios on how families can discuss driving cessation with their loved ones. So I encourage you to look over those, and you have that link available. And Diane, is this available online on a website?
I can make it that way.
That would be great. This way you can just click on the link and not have to type it in, because I have lots of links in this talk. So the Assessment of Driving-Related Skills is a formal program supported by the AMA that includes vision, cognition, and motor function evaluation. And this is the link for your resources. In terms of vision, look at acuity, visual fields, but most of all contrast sensitivity, which really decreases as we get older. And so if you have less contrast, like if the situation is foggy, for example, it's much more difficult to see. Because of this, the vision changes that occur with normal aging, we need a lot more light to see well. And I remember my mom used to say, "Get out of my light, I can't see my sewing." And I'm like, "I can see fine, what's your problem?" Now that I'm older, I'm like, I can totally relate what she was saying. So a lot of older adults already restrict their driving at night when vision is impaired, but also weather situations can impair driving too, especially here with snowstorms. So the contrast charts are usually done by occupational therapy, but we could do those in our office as well. Then in terms of cognition, look at memory, visual perception, visual spatial skills, and attention and executive skills. So the testing that we do is not very good, but doing a more comprehensive test like the SLUMS can give you ideas of their visual spatial skills if they don't do well with, for example, the clock drawing and so on. So more on that. So these are test combinations. This test combination is about 85% sensitive and specific. That is about the best we have. Most of them are only about 70%. This is the maze test. The trail making test A. You draw one line from 1 through 8. And then the trail making test B is more challenging. You have to alternate A's and B's. So, it is the best test that we have, but it's not great either. It only has about a 70 to 80% sensitivity and specificity. But that is the one that I would recommend using. That is the most studied if you only have time for one test. But the combination, increases your identification.
So you drop from 1 to A to 2 to B.
You got it, exactly, yeah. Mhm. So this is the receiver operating curve, and the trail making test B is the best one on this, but it's not great either. Optimally you want it all the way in the corner, and a diagonal is like coin toss, like 50%. So this is the study to support the trail making test A, and the cutoff is 48 seconds, and for the trail making test B is 108 seconds. Cognitively impaired drivers, what you want to do is the combination of screening tests, but also look at physical functioning, visual acuity, working memory, and the sensitivity and specificity is not great. Trail making test B, clock drawing and slums, has a little bit better, but the area under the curve is also not great. It's up to 80%. So for clock drawing test, what I usually do is I draw a big circle and I'll say, put in the numbers and let the hands show 10 after 11. And if you don't say that, if you just say, mark it as 10 after 11, they might draw you a digital clock. Then you won't know. Also, if you don't say put in all the numbers, they might just put in hash marks. And you want to say 10 after 11 because otherwise you wouldn't catch that patients may not have enough executive function to put the hands at 10, at 11 and at 2, but put the hands at 10 and at 11 because they cannot abstract anymore. And the slums has 10 to 11 on it. I encourage you to use 10 after 11. That's where all the research studies have been done. But there's still a high overlap with the clock drawing test between cognitively impaired and cognitively intact patients. So all these tests that we're doing are not 100%. The timed up and go test you're probably already doing for falls assessment. It's the easiest test to do. Just get up, walk to the door, turn around, and sit back down. Alternating foot tap test. Thank you, Diane, for the ring binder. I asked her to provide me with one. So I usually use a ring binder, put it on the floor, and I ask the patient to tap their foot from one side to the other. It is an indicator on how fast they can go from the gas to the brake. And a large ring binder is about the right height that you need to assess it. And the patient should be able to do 5 in less than 5 seconds, so less than 4.8 seconds. So differentiate normal aging changes and dementia. Problems with judgment, less interest in hobbies, not being able to do some of the things that they used to do. Start with the IADLs, the executive function things such as getting lost, doing your finances, cooking Thanksgiving dinner where you have to start the turkey 6 hours before the rest of the meal. Those are things to ask about. Making appointments, putting medications together. Those correlate highly with driving ability. Driving simulation has become increasingly more popular in the recent years, but it's also not the bee's knees. The sensitivity and specificity is also only about in the 70% range. So then what can we do? I refer a lot of my folks to PT and OT for assessment, but also for training and recommendations, because they might have some different ideas of what I can also offer. And then there are specific driving rehab specialists, and CarFit is one of the options through AAA and AARP.
I just had a question about PT/OT. Are they, will they do any of these specific tests themselves if you send them there for the evaluation?
Yeah, so there are some driving assessment clinics, and Madison has one through Meriter and one through UW, and their occupational therapists will do the assessments.
Our Portage Hospital has one also.
Excellent, great.
Oh, I didn't know that.
Thank you for sharing that. Do they do a road test along with it then?
they'll either recommend a road test or say
Okay.
yes, no, or only with road test that they pass. So
Okay, great.
Then they go, I think, to the DMV for that.
Yeah, let me just repeat that for the recording. So Portage Hospital has a driving evaluation clinic, and they don't do a road test, but they'll make a recommendation, either yes, no, or only with road test, and then refer them to a road test.
What's the reliability of a road test?
That is the gold standard. That's what we use, but we don't have anything else to gauge it by.
Okay.
Yeah.
I mean, that's what I tend to do, but I just think of my mother. We had she lived in a small community, and people would say, your mother's not safe to drive anymore. We see her going over the center line, and she was kind of short and had rheumatoid arthritis. And so we made her take a road test. My sister and I did, and she passed.
All right.
And people would say, she still crosses the center line when she's driving.
Well, so the comment was that this driver was veering over the center line and got a recommendation to get a road test done and passed the road test. Well, nowadays the cars have a lane assist.
Right.
So you might want to invest in something like that.
Yeah.
You had a
Still
question?
reliability, I mean, has it been studied, the reliability of the road test?
That is considered the gold standard.
I know it is, but I was just wondering if it was studied.
Yeah, I don't know of anything,
Okay.
because then it would be interesting to look in the follow-up how many crashes occur, how many
Right.
traffic tickets and so on. But I have not seen any evidence on that.
Okay.
Yeah. You had a question or comment?
Well, so getting to this, I've done this before where patients have just been panicked that they can drive, and it's clear to their family and me that they shouldn't be driving. And I said you need to have a road test, and if you can pass. I've never had anybody who's passed it. Usually people just decide not to do the road test and not drive anymore. But I was going to ask for further comments on whether or not that's a reasonable thing to tell people that they need to, if they feel that they can drive and it's pretty obvious to you that they should not be driving.
Yeah. So the comment or question was, is it reasonable to then require a road test before you allow them to drive? Absolutely. And I will oftentimes say, I will prevent you from driving unless you do a road test if you really insist on driving. But I don't think that you're capable of driving anymore, and I recommend you don't drive. And then if they do a road test and pass it, that's one thing. But like you say, also most patients then don't do the road test. So the evaluation through the driving evaluation clinic in Madison also does not include the road test. Where I had practiced before in North Carolina, they did a road test with it, and it was very interesting as a student and as a resident to go through that and watch that. It was really fascinating. They also have a large board on the wall that tests reaction speed, kind of like those whack-a-mo's that you have to hit the lights as they pop up. It was just really fascinating. It's quite comprehensive what they're doing. These are some assistive devices for patients with arthritis, and one of my residents said, "Oh, my grandfather had one of those, and he called it the honey wheel. I could steer with one hand and put my arm around my honey." The gear shifter on the left is for patients who have severe arthritis in the thumb. Nowadays, I rented a car recently that has just a knob that you dial, so it's a digital gear shifter, which is even better. Then the convex mirrors expand the visual field to the blind spot for patients who cannot turn their head because of arthritis. So I usually write a prescription and print it out so that the family can put it on the refrigerator and show it to the patient whenever they want to drive. Dr. Hamrick said for you not to drive. See? End of story. Takes the family out of the situation. And I usually say, what if you hurt somebody? What if you killed a 2-year-old trying to cross the street? And most patients then have enough insight and say, yeah, okay. However, some patients, like my patient with frontotemporal dementia, who don't have any empathy at all and no social graces, he would care less. But then I pulled out all the stops and I said, what if you got sued and you lost all your savings and couldn't leave any inheritance to your children? And that did it. So, be creative. But have a plan in place when you discuss it and have some options available. So for my patient, Then the daughter, who was a physical therapist, came up with this idea and said, the youngest person in the car always drives. And his wife was younger, and of course all the rest of the family was younger, so that was an easy solution, and he bought into that, so that can be helpful. So the driving contract that I showed you earlier, start that early in the disease process before driving becomes an issue, and that will make things much easier for the family later on. Because patients, even if they lose insight, they will recognize their signature at the bottom of that letter, and they'll still be able to understand that then. Then the videos, the Hartford book on driving, and Signs of Unsafe Driving. These are all just resources for you that you can look at. So legal and ethical responsibilities. Physicians are encouraged, but in Wisconsin not required to report. In states that have required reporting, there's higher reporting incidence, but Wisconsin does not have a requirement. So while we can contact the DOT and the Department of Motor Vehicles about a patient that should not be able to drive anymore, the ultimate where the rubber meets the road is when patients don't drive, because you can take their license away, but they might still drive. So you need to make sure that the patient is not able to drive if they don't have the insight. And for some patients who might have been a mechanic in their prior life, you have to become quite creative how to disable the car, file down the keys, but they might hotwire the car. So filing down the spark plugs, disconnecting the distributor cap, or putting something in there so that that it looks like it's still connected. So my families have become quite creative over the years of trying to disable the cars for highly capable patients. So the laws in Wisconsin, after a coronary artery disease with PTCA, it's 1 week of not driving, and after a CABG, it's 4 weeks. With an arrhythmia, like in our patient, the cessation until we control the symptoms. So identifying the cause and then controlling the symptoms is what determines when the patient goes back to driving. So there is no set time frame for our patient that fainted to go back to driving.
That says general recommendations, but you said this is a rule, a state rule?
Yes, so those are state laws.
It's not it's a law. Okay.
Yeah, the 4 weeks is a law after CABG, and the PTCA 1 week is a law in Wisconsin. And for CVA and syncope, there are no strict guidelines, but after TIA, you have to have an evaluation, and then once the symptoms are resolved, patients go back.
Those don't follow the rule of altered state of consciousness in 3 months. I always tell people that state law is this is an altered state of consciousness and it's 3 months.
So for seizures, it is 3 months.
Well, that's for seizure, but I mean, if you have CVA or if you have repeated TIAs, I mean, not just one, but repeated, I mean, to me, that's altered state of consciousness, or syncopal episodes, and they're unpredicted when they can occur, that's still kind of altered consciousness.
Right, but the guidelines state to just wait until the symptoms are resolved.
Okay.
And that makes sense.
The rules you're stating are general rules, or are they commercial driving rules?
Those are state rules.
State commercial driving or general driving?
I don't know about commercial driving, just general
That's
driving.
trucks and buses.
So for commercial driving, that is probably very different. Then it might have a 3-month rule after altered state of consciousness. But for general driving, it's not. After seizure in North Carolina, it was 6 months. In Wisconsin, it's 3 months of not driving. So in summary of the recommendations, recommend selecting routes that are that minimize or eliminate requirements for high-demand maneuvers, such as left turns, for example. Oftentimes patients don't accelerate fast enough on a left turn. And one of my patients was rear-ended when he made a left turn because he didn't accelerate, and somebody turned to the left in a driveway to the right of him and accelerated and rear-ended him. So just, high-risk maneuvers. And then discuss driving cessation in patients that are 70 and older, definitely, with a plan of what will you do when you cannot drive anymore. California has a requirement that each year after age 80, patients have to do a roadside test. Yeah, not in Wisconsin. So, resources. These are links for these resources here that you have access to. The AMA Physician's Guide. And then UW Driving Clinics. Yes?
We have that resource in the library.
Great. Excellent. So you have those resources in your library. Excellent. Thanks, Diane. And these are the connections for Madison. Maybe you could provide the phone number for Portage Hospital Driving Clinic. And this is the link to the DOT for reporting unsafe drivers. Any questions or comments? Yes.
I'm a DOT examiner, and I don't infrequently get people that are referred by the police department because they walk into the walker or because they were cited in an accident or something like that, and have basically a complete DOT type physical. So I would assume that you probably try to tack on some of these tests in addition to the normal DOT physical. It would seem wise.
Exactly, yeah. So the comment was that as DOT examiner, she gets referrals oftentimes from the police because patients are walking in with a walker or that have had a citation. And then adding some of these testing to the routine DOT physical is a good idea. Yeah, I agree. Because they oftentimes don't measure cognition.
On the clock draw, we do that routinely through our annual well visits. If that's abnormal, could you just say this is evidence that you have this visual spatial, you shouldn't drive, or do you feel that if that's abnormal, you would need to have more testing?
So it depends on the patient. If that is the only thing that triggers me, then I would do more testing. But in most cases, that the clock drawing is prompted by us having other suspicion or families being concerned about the driving. In that case, then I use the clock draw to alert them to the deficits, just like you said. I will then say, do you think this is a normal clock? And they look at it and they say, no. And then you have a big surge of dopamine in the brain, and you have about a minute of alertness that patients will remember afterwards, even though they might have memory problems. And that is the time to pounce on it and say, don't drive anymore. Or it's time to place you into a facility when I do a dementia workup and that comes up.
So if you say don't drive, you give that prescription, do you then automatically send that to DMV?
No, I don't routinely do that because the issue is not their driver's license and removing their driver's license. The issue is that they should not drive, whether if they have a license or not, because the DMV can really just revoke the license. And yeah, that might be helpful, but I mean, the family can also take the license out of their wallet. The issue is really that oftentimes patients still will drive even though the license has been revoked. So getting them to not drive is the key. All right, well, thank you so much.
This is harder than it sounds, though.
It is. It's
Yeah.
very hard. Absolutely.
And I've seen such serious depression in people.
Yeah,
Their lives change.
exactly.
It's a big deal.
Yeah. But I also then discuss with them, it might be good for you to go into a facility so that you have communication with other people and they have activities. And I encourage you to go to a facility before you have memory problems so that you learn your way around and can participate in the activities and enjoy those activities and get to know some of these patients. And some of my patients heed that advice, and some of them who already have advanced dementia just don't have that insight, and then they don't do it. And then it's very difficult for them to find that place, and then they'll always say, oh, I want to go home, I want to go home. So having that conversation early in the dementia process is really critical, and trying to get the patient placed before it becomes necessary if there are no family resources. And placement is always just a social admission. If the family cannot have the support at home, that's when the patient needs to be placed. But if you have 10 children and each of them take turns for a few days to take care of mom in the home, she can stay in the home. Or if the family has enough resources to pay for 24-hour care in the home, yeah, that's fine too. So it's really just a social reason for placement.
We have somebody in the audience who's doing that. And
We're doing that. I'm
I'm the oldest of 8.
Wow.
It's hard. And even with
Absolutely.
8, you would think that's not so bad, but it's hard.
It's really hard.
Yeah.
They did a study, and the caregiving for a patient with dementia takes 67 to 110 hours on average a week. That's 2 full-time jobs.
Yeah.
Yeah, absolutely. It is very hard. And when I have families that do that at home, I always praise them, and I'm like, how can I help you? What do you need? What resources can I provide for you? And the Alzheimer's Association, the Alzheimer's Alliance, the Senior Center are all good places to look for resources.
I know for some
My hat off to you. Thank you.
For some of the families, the keys get lost.
Yeah.
Exactly. That's a good
You
idea.
can't find the keys, you can't drive the car anymore.
Right. And that works well when patients don't have much insight anymore. They just can't reason through that anymore. So having the keys lost. Okay. Great. Thanks so much.